This video will guide you through the systematic interpretation of an ECG. Nowadays, most computerized ECGs have a report printed on it, but it is our job to check whether it is correct or not in the context of the clinical history. First, we will begin with identification of the ECG. This will make sure that you are reading the ECG of the concerned person. For this, check the name and age printed on the ECG. Age is important because what is normal for an adult ECG may not be so for a child. Next, we will check the standardization pulse. Usually, standardization is 10 mm for a millivolt. It should be a nice rectangular pulse. If the complexes are very tall, ECG may be taken at half standardization of 5 mm per millivolt. Double the usual standardization with 20 mm per millivolt can be considered for very small complexes. ECG paper speed is printed at the bottom of the tracing and is 25 mm per second usually. It may be taken at double speed or half speed occasionally. If it is taken at double speed, it will resemble a bradycardia, and half speed tracing will look like a tachycardia at one glance. Rhythm is checked to see if it is regular or irregular. If it is irregular, look for patterned irregularity or total irregularity, which is also called irregularly irregular. Here the patterned irregularity shown is a trigeminal rhythm. Two narrow QRS complexes are followed by a premature wide QRS complex. Totally irregular rhythm shown here is atrial fibrillation. Heart rate can be calculated from the RR interval between two consecutive R waves. 1500 divided by RR interval in millimeters will give the heart rate in beats per minute. 1500 millimeters is the product of paper speed 25 millimeters per second and 60 seconds in a minute. For quick calculation, 3 large squares or 15 millimeters will correspond to 100 per minute. 4 large squares or 20 millimeter will correspond to 75 per minute, and 5 large squares or 25 millimeters will correspond to 60 per minute. When RR interval is different from the PP interval, atrial rate and ventricular rate should be mentioned separately. Ventricular rate is calculated from the RR interval and atrial rate from the PP interval in a similar fashion. In an irregular rhythm like atrial fibrillation, average ventricular rate can be calculated using an average of 10 RR intervals as illustrated here. If each P wave is followed by a QRS complex in a regular sequence, it is usually sinus rhythm. If the rate is between 60 to 100 per minute, it is called normal sinus rhythm. Sinus bradycardia has a rate below 60 per minute and sinus tachycardia a rate above 100 per minute. In atrial fibrillation, there are no P waves. Instead, there are irregular fast fibrillary waves. RR intervals are totally irregular. Next, we will check the waves, intervals and segments in the ECG in a sequence. P, PR interval, QRS complex, ST segment, T wave and QT interval in that order. Normal width of P wave is up to 2.5 mm. If width is increased, it is suggestive of left atrial enlargement. Normal height of P wave is up to 2.5 mm. If height is increased, it is suggestive of right atrial enlargement. If both width and height are increased, it is biatrial enlargement. Wide notched P wave in left atrial enlargement known as P mitral. Tall peaked P wave in right atrial enlargement is known as P pulmonale. PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. So it includes P wave and the PR segment. Normal PR interval is 120 to 200 milliseconds, which will correspond to 3 to 5 millimeters on standard ECG paper. When the PR interval is prolonged, it is called first degree atrioventricular block. 1 millimeter will correspond to 40 milliseconds at paper speed of 25 millimeters per second. So PR interval of 8 millimeter will be 320 milliseconds here. This ECG also shows sinus bradycardia with heart rate 43 per minute. For the QRS complex, we will check the width to see if it is wide QRS or narrow QRS. Normal QRS duration is less than 3 mm. If it is 3 mm 120 milliseconds or more, it is called wide QRS. QRS axis can be checked next, which has been detailed in another video on this channel. In short, if the QRS is positive in leads 1 and AVF, the QRS axis is normal. If lead 1 is positive and AVF negative, it is left axis deviation. If lead 1 is negative and AVF is positive, it is right axis deviation. If both lead 1 and AVF are negative, it is known as northwest or indeterminate axis. Low amplitude of QRS complex can be seen in pericardial effusion, where there is generalized low voltage complexes as the fluid covers the heart. Low voltage is defined as less than 10 mm in chest leads and 5 mm in limb leads for the QRS complex. QRS alternans is seen as alternating QRS complexes of different amplitude, well seen in V1. Tall QRS complexes are seen in ventricular hypertrophy. Abnormal QRS patterns will be looked for next, like RSR prime pattern in right bundle branch block associated with a wide QRS complex. A wide notched R wave in V6 is seen in left bundle branch block. Pathological Q waves may be seen in myocardial infarction. Pathological Q wave has a width of 40 milliseconds and depth of at least 25% of the ensuing R wave. ST segment elevation is the classical finding in ST elevation myocardial infarction. ST segment depression may be seen in acute ischemia as well as in ventricular strain pattern. Tall tended T waves can be seen in hyperkalemia. Inverted T waves can occur in ischemia, hypertrophy and conduction abnormalities. QT interval is measured from the beginning of the QRS complex to the end of the T wave. QT interval prolongation can predispose to serious forms of ventricular tachycardia as shown here. QT interval corrected for a heart rate of 60 per minute is known as corrected QT interval or QTC. If you like this video, kindly like and share it and look out for the next video in this series. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.